Lovely greetings to all my friends, colleagues, and medical students around the globe. I'm Dr. Rami Rafat. I am ECFMG certified cardiovascular specialist. It's my pleasure to introduce for you my new ECG learning course. I have made all my efforts to make it in a simple, well-organized way to help you interpret, diagnose, and differentiate many ECG challenges to help your patients. As I always say, ECG is a cornerstone in medical practice because simply it saves lives. You can save your patient life because you can make a correct diagnosis of strip of ECG in your hand. Suppose your patient has a chest pain and you missed that he has ECG changes that correlates with acute coronary syndrome. Your patient will die. Suppose your patient is coming to you in the ER with lightheadedness, sweating, and palpitation, and you missed that he has a very rapid atrial fibrillation. You can leave him without treatment and he will suffer. He may have a big heart problem like heart failure or stroke because you missed the diagnosis. That's why ECG is very important. I always prefer to start ECG learning with cardiac cycle. So throughout this course, we should learn cardiac cycles summary, conduction system anatomy, we can pass through it, cardiac muscle action potential, automaticity, and the electrical activity because it gives us the knowledge how ECG has been formed, how the electrical activity and the conductance throughout the heart is working. Arrhythmia formation, which is very important and interesting as well. ECG interpretation, how to make a full comment on ECG strip. Here I'm talking about a resting ECG, 12 lead resting ECG, because we have another investigation for cardiac problems, which is exercise ECG. But here we are talking about the resting ECG. Who can join us? Of course, medical students, general practitioners, all medical grads preparing for USMLE. By the way, I am a USMLE courses instructor. PLAB, AMC, MRCP, MCCEE, all are welcome. Cardiologists, of course, and internists, emergency and the ICU doctors, you are all welcome to join us, and we can share our expertise together. Let's start our course. What is ECG? ECG is the electrocardiogram, that's translation of cardiac muscle electrical activity into waves to help us diagnose cardiac muscle disease, plus or minus electrolyte imbalance or drug toxicity. All these conditions can be diagnosed with ECG, and also it can be followed up with ECG changes. For example, you may have a patient with an acute MI, ST elevation MI. After we give him the guideline medical therapy, or he had a PCI for the coronary, then you can notice the changes that happen on ECG to say, yes, he is recovering now. So that's very important for follow-up. For example, another example, your patient has a very rapid AF that's acute before passing 48 hours. You give him IV amiodarone to restore the sinus rhythm. You see on the spot on the ECG that his rhythm has been restored to sinus rhythm. After 2 weeks, he came into your clinic again, and you make another ECG strip to make sure he is still in sinus rhythm and he didn't get a fab back. right? So that's very important for diagnosis and follow up of our patient. The cardiac cycle. How cardiac cycle starts usually? The cardiac cycle starts with atrial systole. You can, because it's a cycle, you can start from any point, but actually let's start from the atrial systole. The atrial systole is followed by isovolumetric contraction. Isovolumetric contraction means that the cardiac muscle is contracting, but it's like increasing the tone in the muscle without changing the volume. It's isovolumetric, which means that the atrial systole has pushed all the blood inside the atrium to the ventricle, and then the ventricle muscle tone is rising to cause isovolumetric ventricular contraction at a point that the pressure can cause opening of the aortic and pulmonary valves. Then a rapid ventricular ejection can happen, and then reduced ventricular ejection can happen. That's followed by isovolumetric relaxation. The cardiac muscle tone, the ventricular muscle tone is relaxing without filling, without changing the volume. Then the relaxation reaches a point that's sufficient to open the mitral and tricuspid valve. So a rapid ventricular filling from the atria occurs without atrial contraction, just with gravity. And then a reduced ventricular filling should follow, and lately an atrial systole, or you can say atrial kick, to push the rest of the blood is going on, and the cycle is repeating itself. So you have an atrial systole, you have ventricular systole. Ventricular systole has two main components: isovolumetric ventricular contraction and rapid followed by reduced ventricular ejection. All right. The cardiac cycle starts with if I start with isovolumetric relaxation, that's followed by ventricular passive filling, then atrial contraction, then isovolumetric. Then after atrial contraction, the mitral and the tricuspid valve should close, and then isovolumetric contraction follows. That's followed by ventricular ejection. Cardiac conduction system anatomy. We have here the leader of the heart, SA node, sinoatrial node. That's very close to the superior vena cava opening in the right atrium, sinoatrial node, which is having its blood supply from a branch from the inferior coronary artery. And then the electrical activity passes from the SA node to the atria, the right and left atria. The right atria first, then it reaches the left atria through interatrial conduction system, Pacman bundle. After atria is activated, the signals goes to the atrioventricular node, AV node, atrioventricular node, and from the AV node it passes to the bundle of Hess, and then the bundle branches right and left, right bundle branch, left bundle branch. And for your knowledge, left bundle branch is then divided into two major branches: left anterior and left posterior bundle branches, and then Purkinje fibers, which gives the electrical activity to the ventricles. Again, you see You see here the AV node, then the bundle of His, then the bundle branch, right bundle branch and left bundle branch. The left bundle branch is divided into anterior and posterior fasciculi. All right. The cardiac action potential, cardiac muscle action potential. We have two types of cardiac action potential. The fast fibers in atria, ventricle, and Purkinje system, and slow fibers in SA node, AV node, and bundle of His. The fast fibers, how it works? They are major players in the cardiac action potential. Major players. They are sodium, potassium, and calcium. Sodium, potassium, and calcium. I will talk first about the fast fibers action potential in atria, ventricles, and Purkinje system. We have a resting membrane potential at minus 100. In order to have an action potential, you have to go for depolarization, which is the opposite of the resting membrane potential, to make it more positive. So, to have a breakthrough action potential, influx of calcium will happen. Influx of calcium and sodium should happen to have an upstroke of the action potential from a resting membrane potential minus 100 to reach through phase 0 to cross 0 millivolt and then make it positive, so it can reach like around plus 30. And then the sodium potassium channels, which is always fast, will close, and the calcium will start to go on continuously to keep it in a positive membrane potential, not negative one. The calcium will continue to be going inside, which we call it calcium influx. And then the rate of calcium influx can slow down through phase 1 and continue to phase 2, which another player will join us here in phase 2, which is the potassium efflux. You have to know that potassium is always very rich inside the cells. So when you have a positive membrane potential after a depolarization, potassium channels are activated, and then potassium will go out of the cells. That's called potassium efflux. But the rate is balanced because potassium is a positive going out and calcium is positive going in. So you have a plateau phase, which is called phase 2. This one. All right. And then after the cardiac contraction happens, the ventricular systole in phase 2, calcium channels will close, so calcium influx will stop, but potassium efflux will continue. I'm losing now my positive charges, so it will continue through phase 3, and the membrane potential will go directly to the negative way until it goes back to the resting membrane potential at phase 4. And it will wait for another impulse from Purkinje system to stimulate the ventricles to have another action potential which will cause sodium influx, calcium influx. Sodium influx stop, that's the very small drop in phase 1, and then phase 2 continue because the calcium will continue to go inside the cells and the potassium is going out. Then the calcium will stop and the potassium will continue to go out until we have another resting membrane potential and so on. But this is not the case in the slow fiber action potential. Slow fiber action potential happens in the SA node, AV node, and bundle of His, which are the cells that we can call it automatic muscle fibers. Automatic muscle fibers means that they have the power, they have the ability to generate an action potential itself, not waiting from an impulse coming from the SA node, passing through the AV node, His Purkinje system. They can start as action potential, they can be a leaders, but actually we have one leader here in the normal condition, in the physiologic condition, the SA node, because it is having the highest rate of firing and action potentials. Okay, so here the situation is different. The fibers here has no resting membrane potential. In the fast fibers, in the atrioventricular Purkinje system, I mentioned that they have a resting membrane potential, but actually here in the SA node, AV node, bundle of His, they don't have a resting membrane potential. When the impulse is generated and automatic, we reach a threshold that just below minus 30, a negative membrane potential. Then calcium will go inside. Calcium influx happens. When calcium influx happens in phase 0, just like the fast fibers, it reaches a positive membrane potential. Depolarization is now complete. Activation of potassium channels will happen and potassium will go out of the cells to make a drop. There is no plateau here. Calcium will stop and potassium will continue, so it takes the membrane potential down to the negative, to the way of repolarization. And when it is negative again, potassium will be continuously out of the cells, but sodium, activation of fast sodium channels will happen that is not causing a resting membrane potential. It will take it again back to the positive way, and when a sodium current happens to make the membrane potential not resting and goes back to the positive in a very fast way, calcium will go inside again and another action potential will happen. So we'll call this sodium a funny current. Funny current because it never gives rest to these fibers. That's why it's called automatic fibers. It has an automaticity characteristic. So it will continuously generate its impulse. It's not waiting for a stimulus. In the fast fibers, atria ventricles, they wait for a stimulus. They need a push, a signal. But here in the SA node, AV node, and bundle of His, they don't need it. They automatically generate its impulse. But because the SA node has the highest rate of firing and generating impulses, it will drive the heart all the way, right? By the way, back to this slide, all antiarrhythmic drugs have been made based on this info, based on the sodium current, potassium efflux, calcium influx, all are going and to act through working on this mechanism. So ECG basics. There are 12 ECG leads, 6 limb leads and 6 precordial leads. The limb leads are so named because each lead has its positive pole on either arm or the left leg. The precordial leads are named of their location across the anterior chest wall. They are put on the fourth and fifth intercostal spaces, and they complete each other to look at the heart from all views. So we have an EKG composed of 12 lead to cover all aspects of the heart. ECG waves and its correlation with the action potential. At the resting membrane potential, look at this diagram. At the resting membrane potential, you have an atrial systole, so it is correlated with the P wave, and then the impulse will go from the atria to the ventricle, causing ventricular contraction. That's correlated with QRS complex. I said here in phase 2 there is calcium influx. There is much more calcium inside the myocardial cells that cause the actin-myosin linkages and cause contraction. Calcium is very important for muscle fiber contraction, and it's correlated with QRS complex. And then while we are going back toward the repolarization, we will have at this plateau phase the QT interval, ST segment then the QT interval will be complete because we will have full restoration of the membrane potential. So T wave will be representing the ventricular muscle repolarization. So the plateau phase will be correlated with ST segment, and the plateau and phase 3 will be covered in the QT interval. Look at this diagram. You have a P wave from P to QRS complex. We call it PR interval, and then the QRS complex followed by ST segment followed by the T wave, and this is the QT interval from starting of Q to the end of T. Okay, thank you so much for joining me at this lecture. The next session will describe more information regarding ECG. Stay tuned with us. I thank you very much.